this is an area that I think that every family practitioner should feel very comfortable with, and most of you probably do by now. So what I'm trying to do is kind of do a broad-based review of some of the big topics in adolescent medicine for you, and maybe talk about some specifics in the middle here. I love working with adolescents. They're a challenge, and they're a lot of fun, and they're very entertaining. And I think that as family practitioners, you know that, and you get to see them as they're developing and turning into adolescents, and you have the privilege of taking care of them when they're adults and their thinking has become a little more normal. So you're in a great place to really provide excellent care to this group of patients if you can hang in there with them during their teen years. We're going to talk a little bit about consent and confidentiality and how that relates to adolescent patients. A little bit about normal growth and abnormal growth and development, a little bit about adolescent gynecology, pregnancy, and STDs, or STIs as they're more commonly referred to today, sexually transmitted infections, and maybe just a little bit about substance abuse. And somewhere in there, I like to make sure we mention recent immunization developments. Adolescents are unique in that they are your patient, and they are often able to understand and consent for their own care. However, they are still minors, and technically their parents still have the legal authority to consent or not consent for their care. So you're dealing not only with adolescent assent for care, but parental consent for care often. Wherever you're from, there are state laws in place that are there to protect the rights of your minor patient. Some states have more laws than others, and I think that it's very important that you understand wherever you're from what your state's laws are. I'm familiar with Nebraska state laws. Some of you may not be from Nebraska. There's a great organization called the Center for Adolescent Health and the Law that publishes a book that comes out every few years that updates what the most recent adolescent-related healthcare laws are, that I think is a great resource to have. State laws do provide that parents have the rights to a minor child's medical information and the right to consent for medical care. It's important to understand this so that when you're talking with your adolescent patients and you're promising them privacy, you keep in the back of your mind that if everything blows up in your face, a parent can request the adolescent's medical records. Technically, legally, they are the parents. Does that happen in practice? Not very often if you have a good relationship with your patient and with their parent, and if things get hot and heavy, you call them into the office and sit down and have a talk. So it's not something that has happened very often in my experience, but I think it's important to remember that so that you don't promise your patients a right that you cannot uphold. Adolescents and their parents should always be informed somewhere along the line, and in our office we use 12 as this age, that they have the right to confidential care, that you're going to talk with them in the office and you're not going to share everything with the parent. The parent needs to know it and the adolescent needs to know it. And they need to also know that there are exceptions, that if you think that their health is in serious danger, that you have to involve a responsible adult. That may be their parent, that may be Aunt Matilda, it may be someone else, but you have to involve someone and they need to know what the limitations are. There are some cases in taking care of adolescents that parental consent is unnecessary. National precedent states that you may treat an adolescent or diagnose an STD without parental consent. And Nebraska state, every single state in the country has a law on the books with regards to this. And these laws came about in the 70s when they figured out that people wouldn't get treated if their parents knew that they had a sexually transmitted infection. There are also, based on national case-based law and national precedent, an adolescent may be treated for pregnancy treatment and prevention without parental consent. And obviously, there are some adolescents who I will not treat for pregnancy or pregnancy prevention without parental consent. It is really up to the provider to determine if an adolescent can understand the risks and benefits of what you're doing and the implications of it well enough for them to be treated without having a responsible adult involved. That decision always falls back to the healthcare provider. In emergency treatment, never sit an adolescent in the office chair and wait for their parent to come in if they look like they don't know what's going on, if they're not aware of their surroundings. Obviously, you want to start treating them. Get someone in the office to work at getting their parent involved and making a phone call to get consent, but never leave someone sitting in the office without knowing what's going on, waiting for their parents to consent for their care while you're trying to, while you may have a sick kid on your hands. There are many state laws pertaining to specific things. Almost every state, actually I think every state, has laws with regards to HIV testing, that an adolescent may consent to HIV testing. And many states do for substance abuse diagnosis and treatment as well. And other laws are particular to certain states. Some states have laws with regards to does being a parent make you an adult and able to consent for your own care. Nebraska does not. So technically, when I have my 16-year-old in with her 6-month-old baby, she can consent for his shots, but not for her own. All right? So it's goofy, and you have to use some reason when you're dealing with your patients, but it's important to know what the laws state. As far as consent for health care, in most states, 18 is the age of consent, 18 is the age of majority. Not in Nebraska, it's 19 here. I don't know why that is. There are 2 other states where it's 19 too, and all the rest are 18. I think the others are Wyoming and possibly Arkansas. There are other exceptions, and a minor can petition the state to become emancipated. In that case, they consent for everything. Some states recognize being physically independent of your parents for a certain length of time as an emancipating thing. For example, if you've been away living independently for 3 months or 6 months. Military enlistment in many states is a condition of being an adult and consenting for your own care. However, in most states you have to be 18 to be in the military, and so it's a moot point because in most states 18 is the age of adulthood. Marriage in some states makes you no longer a minor, and that is true in Nebraska. You do have to be 16 to be married with the consent of one legal guardian in the state of Nebraska. And that age varies from state to state, so it's important to know that. I know in Missouri the age is 15, and I think in Kansas it might be 14. Parenthood, as I said before. The mature minor doctrine is something I think everyone should be aware of. Many states, about 1/3 of the states, have a law on their books relating specifically for an adolescent to have the ability to consent for medical care without their parents' consent. And those are called mature minor laws. Nebraska does not have a mature minor law. I know Minnesota does. Iowa, I'm not too sure about. And what a mature minor law says, the gist of them are something like this, and they make a lot of common sense. If an adolescent patient is X years of age or older, and usually it's 14 or 15, if they are able to understand the risks and benefits of the proposed treatment, so they're making sense, basically their cognitive skills are pretty decent. If the medical treatment is necessary by conservative medical opinion, in other words, they've got strep throat, you want to give them penicillin. It's a reasonable treatment. And if there's a good reason for not informing their parent, and that may be, I don't want to tell them they'll kill me, or they're on the streets and I don't know where they are. There are lots of good reasons for not informing parents. Then you may treat them without parental consent. I use this, even though there is not a state law in Nebraska, as a tenet of practice for my patients if I can't get a hold of their parents. All right? If the adolescent is reasonable, if it's appropriate care, if it's not going out on a limb, if they understand what's going on, and by understand what's going on, usually I incorporate some they'll follow up idea into this. If I get a phone number from an adolescent, I tell them I got to call you and make sure that you're okay. If I can't get a hold of you, I'm going to talk to whoever I need to make sure you're okay. Then I will treat them without parental consent. But you have to understand that really the most important part of that is the understanding, the comprehension, the informed consent piece, I think. Adolescents do need to consent to medical record release, to their own medical record release. That's appropriate. To STD screening, it is inappropriate to do a urine DNA test for gonorrhea and chlamydia without the adolescent knowing about it. All right, you set yourself up for problems if you do that. for pregnancy screening, for drug use screening, and providing any other care. So though parents may say, yes, I want them to have all these things, really it is inappropriate to do them unless the adolescent knows that you're doing them and why you're doing them. And I think that's really important. You will lose adolescent patients if they don't know what you're doing with them. And it's really important to keep them involved. The reasons that you break confidentiality. I'm sorry, what you've just told me is really serious, scary, frightening. I think that your health is at serious jeopardy. We have to tell someone. Patients tell you that they're thinking about hurting themselves, hurting someone else, or they've been abused in some way. Those are the reasons you really need to break confidentiality. All right, so we're going to move over from there. We're going to jump a little bit into normal growth and development. What's normal and what's not during adolescence. Tanner staging, or SMR, is what you're going to see in the textbooks anymore. Sexual maturity rating for males and females is something that we use loosely to tell us whether we think things are normal or not in an adolescent. Rating breast development, pubic hair development, gonadal development, making sure that things correlate. These are not things that I think that people need to, it's not essential that you need to know, oh, by 15 we should probably have at least Tanner stage 4 breasts and Tanner stage 4 pubic hair and be having our periods. That's good information. What's better information, I think, is that there's a sequence. And the sequence for breast development and pubic hair development correlate a little bit. And if you have one breast development that's very advanced and pubic hair that's not, something's amiss. And the same thing is true for male development. To know that there's a normal sequence, that the sequence starts between certain ages, and that it should be completed between certain ages. And it's helpful for you when you're working with adolescent patients to identify where they're at. If I have a female who comes into me and she's really worried that she's going to get her periods and doesn't know how to deal with it, and she comes in and I see she's Tanner stage 2 pubic hair and breast development, I'm going to tell her, calm down, it's okay, you have a little while. All right, this is not something that's going to happen tomorrow. By the time it does, you'll probably be much more capable of dealing with it. It's okay. So it's helpful to be able to tell your patients that. It's helpful to be able to tell an adolescent male who's 12 who comes into your office for their 7th grade physical, you haven't even started to grow yet. It's okay that you're 4 inches shorter than your peers right now because you haven't even started your growth spurt. And you are going to grow a ton before your time is over. Some of your friends have already started. They may be a lot taller than you, but they're going to be done a lot sooner than you are. So you have plenty of time to grow and catch up. So that's where those things really come into play and are important in helping you with your patients. The order of progression of puberty is helpful to know. In females, usually breast development comes first. Once in a while, they'll get axillary hair first or pubic hair first. But usually, breast development, pubic hair development, and axillary hair development. Peak height velocity right in the middle of puberty. Menarche, onset of periods towards the end of puberty, more at Tanner stage 4 in females. And the reason that I think that that's also important is that if you don't talk with your female patients about puberty until they have their period, you've sort of missed it, because that's at the end of the line. In males, adrenarche, testicular enlargement, pubarche, spermarche, peak height velocity at the end. And keep that in mind, that's your huge disparity between females and males. In females, peak height velocity happens in the middle. In males, it happens at the end. In females, puberty starts earlier than it does in males. So you have a big disparity in when they're growing, which is why all the 5th grade girls are 3 inches taller than the 5th grade boys. What constitutes delayed growth? It's important to know that as far as males are concerned, if a patient still has no gonadal development at 14 years old, they still have prepubescent testicles, volume less than 2 milliliters, very small, no pubic hair, or no pubic hair at 15 years, that's delayed by male standards. Or if it takes them more than 5 years to develop completely once they start development, then you should consider that there might be a problem. As far as females go, if you are dealing with a 14-year-old female with no development, that's unusual. Now you have to keep in mind there are those outliers who have a family history of late development, and those things are really important and play into this. I'm not saying I don't have any normal patients who had no development at 14 years old. I've got a few of them, but they're few and far between. Or greater than 5 years between the onset of breast development and your first period. That's unusual. And not having a period by the time you're 16. Again, that's at the greater than 2 standard deviations beyond normal. And when you're looking at delayed growth and development, you have to look at the reasons and the whys. And most of the time, you're going to know the why because you know the patient. And if you've known them since they were growing up, you have a pretty good idea of what's going on with them. But sometimes it takes a little work. Nutrition is huge. Obviously, in females with eating disorders, you're going to see delayed onset of puberty. And it can affect their final height, for that matter. Constitutional growth delay. These are the kids who are small and are gonna grow, but it's gonna take longer. Okay, these are your late bloomers. And usually, to figure that out, they're really small on the growth chart. You check a bone age, and their bone age and their height age. So if you plot their height out on the 50th percentile curve and see where it is, their bone age and their height age are going to be the same, and they're both going to be less than their actual chronologic age. As opposed to familial short stature, these are the kids always were short, going to be short. Have always been short along the growth curve. And in those kids, their bone age is the same as their chronologic age, and they've had consistent growth over time. Chronic illnesses, any kids with chronic illnesses, whether it's kidney disease, heart disease, asthma, that can affect your development, and it can delay it. Endocrine problems, probably the most common problems we're going to see are thyroid problems, hypothyroidism, growth hormone deficiency, obviously in the kids that are way down on the growth chart. The important thing to remember with some of these kids is they're going to be short, very short, and they're probably going to be overweight. Not always, but a lot of them are overweight as well. And Cushing's disease as well. And then genetic syndromes, short females, think Turner syndrome. It's relatively common, and it's something that is important not to miss because it's gonna have a host of other problems associated with it. When is too early to develop? In females anymore, basically the cutoff is younger than 8. That seems very young, but it is very young, but that's our cutoff now, and that has slid back over the years. So, however, an isolated pubic hair development or breast development all by itself without other characteristics of puberty is relatively common in females. And when that happens, I think a really simple workup with the bone age to make sure that their bone age isn't accelerated, to make sure that you're comfortable that they don't look like they're developing in other ways, that their vaginal epithelium looks like a prepubescent vaginal epithelium, and that they don't have axillary hair, body odor, things like that. I think that is usually as far as most people go, and with close observation over time and working those females up. In males, development before 9 is very unusual, and any kind of early development in males should be considered unusual. That just doesn't happen. Breast development, pubic hair development, isolated, it should be worked up. This is something that should be evaluated, and you should always suspect pathology. From there, I'm going to move on a little bit to slide into adolescent gynecology. Problems that teenage girls have with their reproductive organs can make you their friend if you can help them with them. I tell my residents and my students whenever I'm working with them, if you can help an adolescent with the minor problem, they are much more likely to trust you with the real stuff. So anytime you get an opportunity to help an adolescent patient with headaches, with dysmenorrhea, with acne, you're helping to earn their trust so that they will trust you with the more important stuff when the time comes for that. Dysmenorrhea, all right, dysfunction or pain with periods. Primary dysmenorrhea usually starts right before your period starts or very early when your period is underway. And it's important to remember that. If it's outside of that time frame, then it's maybe likely that you're dealing with another problem besides primary dysmenorrhea. It's often uncommon right after menarche, when periods start. So often you will see girls who come in and say, I don't understand. I've had periods for 2 years and I've never had any problems. Why am I having these horrible cramps now? Well, you're ovulating now. Often the first year or two that you have periods, you're not ovulating, and so you don't have the hormonal fluctuations that you have that cause dysmenorrhea. It's very unusual to have any cramping or pain between periods. If they do, you really need to suspect other pathology. And usually responds pretty well to nonsteroidals in hefty doses. I give my patients 600 or 800 milligrams of ibuprofen, and I tell them the second they feel a little bit of cramping, hit the ibuprofen big time. And usually that's enough to do it. But there are other medications. Naproxen works well. Mefaminic acid or Ponstel works relatively well. There are some newer studies that are looking at fish oils and saying that they really may work pretty well too if you're looking at sort of more naturopathic remedies. And a couple of other things have been, vitamin E has been used in the past, and other things that have been used that the studies are plus or minus on. Differential diagnosis, endometriosis, pelvic inflammatory disease, any teenager who comes in with horrible cramping who's sexually active, I think you have to always keep that in mind. Any kind of outflow obstruction in somebody with cyclic pain with their periods that's really bad. You can have an incomplete outflow obstruction like septate vagina or things like that that are causing problems. So it's really important to always make sure you do a good exam on your patients, make sure that they don't have a big pelvic mass that shows that they have obstruction. Fibroids, pelvic adhesions, and ovarian cysts are often associated with pain. They're sort of the bane of my existence because there's not a lot you can do for them other than trying to prevent them from happening. And my patients who have them are always dissatisfied with what we can do for them if they don't want to be on pills to try and prevent cysts. Dysfunctional uterine bleeding, incredibly common problem. I haven't had a period for 3 months. I've been bleeding for a month and a half. To help me stop this, what can we do about it? Really common problem in teenagers, and as many teenagers as we're seeing these days who have problems with their weight, polycystic ovarian syndrome, metabolic syndrome, more and more and more common to see patients with dysfunctional bleeding. They may have irregular bleeding, they may have prolonged bleeding. It happens very often early in menarche. So in the first couple of years while they're anovulatory, the most common cause of dysfunctional uterine bleeding is having an immature hypothalamic pituitary ovarian axis. You have high levels of estrogen that don't peak enough to make you ovulate, but stay high enough that you're anovulatory. So you have these crazy anovulatory cycles where you don't completely shed your uterine lining and you just get this shaggy proliferative uterine lining that bleeds and stops and bleeds and stops or just bleeds continuously. So very common early in menarche. Things to keep in mind when you're dealing with irregular bleeding. I've had patients come in and say, I'm bleeding all the time, will you please make it stop, who've come from another practice and they're on Depo. Sometimes Depo-Provera makes you bleed all the time, so don't forget to ask them, are you on any medicines, are you taking birth control, Depo-Provera, those sorts of things. So keep that in mind. Pregnancy can make you bleed, and patients will sometimes not tell you they're pregnant, believe it or not. You guys know that, you've been around long enough that you've seen this. But so I always do a pregnancy test in any patient with irregular bleeding. And I tell my patients, this is not because I don't trust you, but believe it or not, I've had patients in the past who told me that they couldn't be pregnant who were, and it's a really horrible thing to not know that because it could really change the way I need to take care of you. So just for every patient who comes in with a bleeding problem, they get a pregnancy test, and that's just what I do. Even if you've never had sex before in your life, I still do it with every patient. Pregnancy, sexually transmitted diseases in anyone who is sexually active. And in a patient who is having very irregular or prolonged bleeding, especially early on in their periods, you have to worry about a bleeding diathesis. You have to consider checking their platelets, their PT, PTT, looking for von Willebrand disease. And you treat these patients based on a lot of different things, but basically the most important thing is if a patient has been bleeding irregularly or for a prolonged period of time, you need to look at their symptoms. If they are symptomatic, if they're starting to have orthostasis, if they're tachycardic, if they have significant anemia, you need to stop their bleeding. And you need to stop it quickly. And the last patient that I had who came in with significant anemia was not too long ago. She'd been feeling tired. She'd had a period that had been going on for 5 weeks, and she was going through about 4 pads a day. And she was still going to school and doing well in school. She had not been sexually active, and she was just really tired and tired of bleeding. And I checked her hemoglobin, and it was 6. So she had bled herself down really well. We stopped her relatively, so you stop the bleeding and you give them iron. Stop the bleeding, give them iron. They need the iron to build their red blood cells back up. If they're healthy adolescent females, it won't take them long. They will build their iron stores very quickly and start kicking out red blood cells like nobody's business. This young lady, we started on iron. I started her on a monophasic contraceptive pill, and for the first 2 days I had her take 4 pills a day. Her bleeding stopped within a day, and then we tapered them down. And within a week, or within 2 weeks, her hemoglobin, was it 2 weeks? It was 3 weeks. Within 3 weeks, her hemoglobin was up to 10, and by 8 weeks, it was up to 14. Okay, and you give therapeutic iron in decent doses, ferrous sulfate, 325 milligrams, 2 to 3 times a day. And she bumped herself up very nicely. Very common story in teenage females. As far as oligomenorrhea or amenorrhea go, prolonged absence of your period. Where's the period? I have had some patients come in, very funny. One patient who came in and diagnosed herself was 15 years old, had never had a period, had development, and she and her mom had been watching a special on television about polycystic ovarian syndrome. And she came in to me and she said, my mom and I were watching this news show and I have this thing. Can you do something about it? Because they said that you should talk to your doctor about it. And she was right. She did. She had that thing. We started cycling her, and she had normal periods, and we got her some help. With normal secondary sex characteristics, so having breasts and having a uterus. Now, it's really important that you know whether your patients have these things when you're dealing with them. So if you don't have a period, you have normal breast development and a normal uterus, then you need to worry about stress. Okay, because stress stops periods. Pregnancy, polycystic ovarian syndrome, all of these things. Thyroid disease are very common in people who have amenorrhea, especially hypothyroidism. Turner syndrome. You can have normal development in Turner syndrome. Sometimes you don't have normal pubic hair development or normal breast development, but many times you have some development that may be considered normal. Imperforate hymen, no period, cyclic bleeding, cyclic pain. Think about imperforate hymen. And don't assume because a patient is 12 years old that someone's, or 13 years old or 15 years old, that someone's looked at her genitals all along while she's been growing up and made sure that they were normal. I always make sure that when I see a patient for the first time, I know all of their problems, and if at any point in time anything comes up with concerns to their genitals, I do an exam because I can't assume that people have looked at that person from the time they were a baby. Ovarian failure, especially in people who have history of other autoimmune diseases or who have had cancer and have been treated for cancer, you have to worry about ovarian failure. And pituitary failure. With abnormal secondary sex characteristics, you're talking about other problems. No breasts, think about Turner syndrome, think about gonadal dysgenesis or no gonadal development. In any patient with hypertension, think about congenital adrenal hyperplasia, the adult variant that isn't discovered usually at birth, and pituitary adenomas. If there's no uterus, then you should think more about androgen insensitivity, or what used to be called testicular feminization, or a congenitally absent uterus. There is a syndrome out there that's called MRKH that's actually relatively common. MRKH is short for this horrible acronym, or It's Meyer-Rokitansky Custer-Hauser syndrome, but basically it's vaginal and or uterine agenesis. And it's relatively common, and it's often not picked up until someone comes in and doesn't have a period when they're 15 and is otherwise developed. They have ovaries, so they have breasts, they just don't have a uterus or a vagina. Pregnancy, common problem in adolescents, one of the most frequent reasons we see teenagers in the office. They come in for a pregnancy test. And I like to encourage people to capitalize on that encounter. When a teenager comes in for a pregnancy test, please make sure you don't just have your nurses meet with them, do the pregnancy test, and if it's negative, send them home. Some kind of counseling ought to be in place to grab those people. If they're positive, obviously, then they're going to need to have a long discussion about what's next. If they're negative, they should also have a long discussion about what's next. This is an opportunity for an intervention of some sort to make sure that they understand, we missed it this time. What can we do to make sure that this doesn't happen again? Let's get some things in place to make sure that you're safe from having a child until you want to have a child. Obviously, the majority of teen pregnancies are unintentional. About 30% or so end in abortion, either elective or spontaneous. And about 50% of teen parents graduate high school by the time they're 18, compared with 97% of non-pregnant teen females. The ABCs of pregnancy prevention, that's the way everyone always looks at it: abstinence, barriers, contraceptives. Abstinence, obviously, if it was my choice, and if it was, I think, most people's choice, a teenager would be abstinent until they were ready to have a family. Unfortunately, I am not there making the choices for my teenage patients. They're making them. So I have to try and prepare them for the consequences of their choices and talk with them about that. And we talk about abstinence. We talk about condom use, both for pregnancy prevention and for prevention of sexually transmitted infections. And I tell them, we call this safer sex. It's not safe sex. There is no safe sex. You put yourself on the line when you have sex with people, and I think most teenagers really need to know that, on the line emotionally, on the line physically, and you need to understand there's no such thing as perfectly safe sex. It just doesn't happen. Even the most safe of patients can get pregnant or get an infection. But barriers help. Contraceptives is a long discussion, and when patients are interested in contraception, I like to ask them what they've heard and what they're interested in first, so that we can talk a little bit about what they know so far, and then I can add to it. IUDs are sort of coming back into favor with young adults, not necessarily early adolescents, but older adolescents, people who are, for the most part, in monogamous relationships and last a long time and work really well, for the most part. You'll always run into someone who has a failure story about an IUD, about every form of contraception. There are plenty of failure stories out there. But the hormonal contraceptives really are very reliable forms of contraception. How do they work? They thicken cervical mucus, they inhibit ovulation, they cause changes in the endometrium that prevent implantation, possibly, mostly by inhibition of ovulation over time is what we've discovered. They also probably alter tubal motility. There are combined contraceptives, meaning both estrogen and progesterone containing, and progesterone only contraceptives that we use today. Combined contraceptives, oral contraceptive pills. Lunel, we used to have, was the monthly shot. It's on the shelf. It's gone for now, and we don't know if it'll ever be resurrected again, but I had a lot of patients who really loved it. The Nuva ring is a new customer, and for the older adolescents and young adults, it's becoming very popular. Flexible ring that you insert into the vagina, you put it in for 3 to 4 weeks, you take it out for a week, you have a period, and then you put a new one in. Very easy to use if you aren't afraid of touching yourself. My younger adolescents don't want a thing to do with it. So usually if they can't deal with a tampon, they probably can't deal with the Nuva ring. The patch is a weekly patch that also is estrogen and progesterone containing. Very popular with teenagers because you just stick it on and forget about it. It's very sticky. I have had some patch failures as far as coming off because they haven't been sticky enough. So I always give my patients, when I prescribe the patch, a prescription for an extra single patch so that if they have a defective patch, they can take it to the pharmacist and get a new one. The patch in the past year, the FDA is trying to black box warning all of my useful drugs I've discovered. And in the past year, they have put a black box warning on the patch because it may be associated with a higher risk of blood clots. There's been one really good study that would argue that. But because of that, you cannot put a patient on the patch without letting them know. This is your risk of getting a blood clot today when you're healthy, when you're not on any medications. Your risk goes up if you're on the birth control pill. Okay? Your risk goes up a little bit more maybe if you're on the patch. If you're pregnant, this is your risk of blood clots. So if you're using the patch to prevent pregnancy, I think you have to weigh those things with your patient, keeping in mind that pregnancy itself is a hypercoagulable state. Now, if you're using the patch for other reasons, then you are increasing your risk, and I think you might need to consider that a little more seriously. But if you're using it to prevent pregnancy, you got to look at the big picture. And I try to talk with my patients and their parents about those things. Choices for progesterone-only contraceptives. There are oral contraceptive pills that are progesterone-only containing. I would be very cautious about using those with adolescents because technically they don't really cover a whole 24-hour time period. They peak at about 8 hours, and then their levels come back down so that probably for the last 3 or 4 hours of every day you're not protected. So if I have a patient on a progesterone-only pill, I usually advise them to take it with dinner. Because it's most effective then during the night, and that's most often when my teenagers are having sex. If they're having sex after school, I tell them to take it in the morning. But I want that to be effective while they're sexually active, if that's why they're taking it. Depo-Provera, another black box warning. Depo-Provera is a great contraceptive. I have patients who absolutely love it and don't want to be off of it for anything. It is sometimes associated with weight gain, and that is the biggest focus of my teenagers, is Depo going to make me fat? And I tell them probably about 1 out of 20 teenagers that I try it on has problems with weight gain on it. I have patients who have been on it for years and have never gained a pound. So it's variable. The black box warning is all about bone mineral density loss. You've probably read some about that. Obviously, if you suppress ovulation for long enough, you're suppressing your estrogen levels, and estrogen is important for bone health. And there are some very well done studies that show that bone mineral density is lost in a small amount in people who are on Depo for a prolonged period of time, over the course of 1 year to 2 years. The studies also show that once you stop taking it, your bone mineral density goes back up to previous levels. So we really don't know the long-term effects of being on Depo for a terribly long time. I do put patients on Depo. I talk with them about bone mineral density loss, and I tell them I think that it's not a lifetime sort of contraceptive, that it's great to use for a while, but because we don't know the long-term effects, I'd rather, as they get older, that we transition them to a different kind of birth control that has estrogen in it for their bone health. The jury's out on whether you should do DEXA scans on these people. I think right now most of the people who know the most about this in the profession are not doing DEXA scans on people to look at bone mineral density unless they have another risk factor for bone mineral density loss. If you have someone who is immobile, then they probably deserve a DEXA scan at some point in time, maybe even before you start them on it, to look at their bone mineral density and decide whether that's the best thing for them. But not just your run-of-the-mill healthy adolescent female. What about the Depo Low? I have not had a lot of experience with it lately. You can use Depo in varying doses, and it's been looked at over time in varying doses, and I think you still run the same risks. If you're using it as a long-term to suppress ovulation, you're probably going to get some suppression, and it hasn't been looked at as far as the bone mineral density. The studies aren't there for it. So I don't think you can say one way or another. I think it's important that everyone knows, if you're starting someone on contraceptives, what the contraindications are. The World Health Organization has contraindications for starting people on contraceptives, and everyone should be aware of. Obviously, most of these do not apply to adolescent patients. That's the nice thing about it. The one that I run into more than anything else is migraine with aura. I have teenagers who have migraines, and if you have a migraine with focal neurologic symptoms or aura, it places it at a category 3 with the contraindications, which means you probably should not use combined contraceptives. You can use progesterone-only contraceptives, but combined ones are contraindicated. I think that it would be wrong to present a talk about adolescent medicine without talking for at least a minute about emergency contraception. This has been a huge topic in the news over the past couple of years. The single form of emergency contraceptive that is packaged out there for use is called Plan B. Plan B, the makers of Plan B have gone to the FDA for over-the-counter approval of this medication, and this has been held up for 3 years now in FDA hearings, not because of any problem with the drug, and I'll just leave it at that. This is an excellent way to prevent pregnancy in someone who, as I like to put it with my patients, had an oops. All right, the condom broke. You forgot to use the condom, you suddenly remembered you forgot your pills for the last 2 days, you know you don't want to be pregnant. It works by all of the same methods basically that birth control works. It's basically a huge dose of progesterone that you take to hopefully inhibit ovulation, alter tubal motility, and it may prevent implantation as well. So I let patients know about that, and if they feel that that is inappropriate and that to them would be an abortion and they don't want that, then it's not for them. But I think every patient deserves to know about it. Obviously, people who have been victims of sexual assault need to know about this. If taken within 72 hours, it's very effective. If the sooner it's taken, the more effective it is. Efficacy slides as time progresses. And there are pretty good studies that show that there is some efficacy up to 5 days after intercourse. So my patients, I let them know about this. You can use oral contraceptive pills as emergency contraception. There are several websites that anybody can get to that can tell you how to use the pills in your pill packet as emergency contraception. However, it's easier prepackaged as Plan B because the progesterone-only version does not give you the vomiting and the stomach aches that the progesterone and estrogen containing combination does, and often doesn't even need pre-medication. If you're using pills and they have both estrogen and progesterone in them, you ought to pre-medicate your patients with something for nausea because chances are pretty high that they might vomit it back up. And the other thing is this is 2 pills. The historical way to deliver it is you take 1 pill right away and you take the second pill 12 hours later. However, a couple of really good studies now that show that you can take them both at once as soon as possible, and that's it. So you don't have to worry about waking up at 3 in the morning to take your second dose, which was always a problem because you never take your first dose at 7 in the morning. You always end up taking it later in the day by the time you've called the doctor, and so you have to set your alarm to wake up in the morning, and then the second dose doesn't get taken, etc. Yes, question? No? That's all I'm going to talk about that. Sexually transmitted infections, any problem that your teenagers present with, always think sexually transmitted infection. I just do that because often it's the answer. Obviously, there are lots of different sexually transmitted infections that we deal with, the same ones that you deal with in adults, you deal with in your adolescents. Explaining it may be a little more difficult with some of your adolescent patients whose understanding of things is a little more simplistic. Vaginitis, cervicitis, and urethritis. Your big players are chlamydia and trichomonas. Ureaplasm and mycoplasma fit in there too. So if you have a patient who's got urethritis and isn't chlamydia positive, treat them anyway with azithromycin because it's going to take care of those other things. Remember, males, we can't really test for trichomonas. So whenever you have a female who has trichomonas, we really have to have their partners get in and get treated too because they can carry it, but there's not a good way to test them for it. Gonorrhea is still a big, huge player out there. We're using ceftriaxone IM or fluoroquinolones. Technically, fluoroquinolones are still not approved for adolescents under 18 years of age. I use it in kids who I think are sexually mature because their bones are done growing by then. And the whole issue of the fluoroquinolones is cartilaginous destruction of mice and those sorts of things. So I think you're safe most of the time, and it's a one-time dose. It's not going to hurt them. And Suprax is actually now, I think, available in liquid form. I don't know if they've started making the pills yet or not for grown-ups, but we have Suprax back on the market, I know, in the liquid form, and we're hoping that they're going to make the pills again because that works great for GC too. And then it's not a fluoroquinolone, so we can use it for our teenagers. Bacterial vaginosis, you can treat with a one-time treatment dose or a 7-day course of therapy. Metronidazole, you guys all need to know. Obviously, you've done this before. When you dispense it to your patients, make sure you give them the horrible, scary warning about alcohol. You know, don't drink alcohol while you're taking this medicine, or you're going to puke your guts up, that sort of thing. Yeast infections obviously are a big cause of that, but when my teenagers call me and say, I need some medicine, I've got a yeast infection, I usually want to see them because unfortunately a lot of them aren't yeast infections. So, diagnosis, visual inspection. You can't diagnose something if you don't look because sometimes dysuria is herpes. All right, I've had more than one patient who came in, follow-up from the emergency room, treated for a UTI, who had white cells in their urine, dysuria, had been asked to pee in a cup, diagnosed with a UTI, and nobody looked at her bottom and saw that it was covered with ulcers. Okay, so don't forget about those things. And bimanual exam. Wet mounts are incredibly valuable in diagnosing trichomonas and bacterial vaginosis. If you think they've got yeast, you do a quick KOH prep. There are DNA tests now for vaginal pathogens. These are interesting things. You can use a vaginal swab of secretions, stick it in a tube and send it to the lab, and they'll tell you if they're positive for Gardnerella, trichomonas, or Candida. And the test here that we can run comes back in about 2 hours. Not every place has this test, and I still do wet mounts because I like to tell my patient right then and there what they've got. The tests are very accurate, actually, these DNA tests for vaginal pathogens. And for a patient who doesn't want to be examined, which if a patient refuses to be examined, you can't examine them. Well, that's assault. Okay, so if I have a patient who doesn't want to be examined, I'll give them the swab and I'll send them to the bathroom and I'll say, take this swab and swish it around in your vagina and hand it out the door to me. And I'll stick it in the tube and send it, or sometimes I do a wet mount on it first. So that's an easy thing to do. Urine tests now are widely available. DNA testing for chlamydia and gonorrhea, incredibly accurate. The best way to use them is on a concentrated urine specimen, so hopefully your patient hasn't gone to the bathroom in the past 2 hours before they use the test, and the most accurate specimen is a first morning specimen. These are great tests to use when teenagers come to your office for a healthcare visit and they're sexually active. Hey, you're here, pee in a cup for me. Let me screen you for gonorrhea and chlamydia and make sure that you're healthy because you can have these things and not have symptoms. And you're not doing anything invasive. We pick up a lot of positives that way. Vaginal swabs, again, for PCR and LCR for chlamydia and gonorrhea, and cervical or urethral swabs still are the standard of care. In any patient who's been a victim of assault, cultures are still the gold standard. If you are working someone up who has been assaulted, you can do the DNA testing as far as the DNA test for chlamydia and gonorrhea, but you have to do the cultures because they're the only thing that stand up in a court of law. Pelvic inflammatory disease, keep in mind that PID is uterine or adnexal tenderness or cervical motion tenderness in a sexually active female with abdominal pain. That's it. You don't need anything else to diagnose PID. You don't need a positive GC or chlamydia test because it can be anaerobic. All right, so that's PID, and so your threshold for treating for PID should be very low in teenagers who are sexually active. There are lots of supporting criteria, but you don't have to have those. And the complications of PID are huge. Infertility, about a 25% risk of infertility with every episode, and it's important that teenage patients know that. You do not have to treat PID as an inpatient. If you know, you can follow up on the patient. Syphilis is much more rare in this area, although I saw a chancre last month. So it's not that uncommon that you'll never see it. And I think that you need to be aware that it can look like other things too. Obviously, the treatment or the test of choice is a blood test for syphilis, and the treatment is penicillin. Herpes, every teenager knows about herpes. I don't know how they know so much about herpes, but they do. They know that when you have herpes, it's for life, and every time I've ever told a teenager they have herpes, there is a complete breakdown. They are crying and upset and want to know how this happened. It's a horrible scene, it really is. They know about herpes and they know that you can't ever get rid of it. And they're usually devastated by it. It is the great imitator. If you see something funny in a genital area, think herpes. I have seen several patients that just didn't really look like herpes, but over time they had a positive test. And I've been warned about that many times by people wiser than I. So I pay attention to it and keep in mind that anything that looks funny in that area can be herpes. Treatment for primary herpes, a 7 to 10 day course of acyclovir, which is now generic and much cheaper, yay. For recurrent herpes, only a 5-day treatment course. And if someone has more than 6 episodes a year, they probably ought to be on suppressive therapy for a while to see if that doesn't help them, because it really can make you miserable. HPV. How do you diagnose it? Well, you see warts. That's about it. You do screening with a visual inspection. Obviously, Pap test is your other diagnostic tool for HPV. Slides are still done in some places, but most places are going to thin preps with the little container of stuff that you send to the lab, that you shake up and send to the lab. In teenagers, the recommendations have been changing over the past few years for what to do, when to do Pap testing, and how to respond to abnormal tests. The American Cancer Society guidelines are now that you should have your first Pap test within 3 years of becoming sexually active, with the emphasis on being later, not earlier. You don't want to do that test a month after they've become sexually active. You want to wait till closer to 3 years. Because we know that a lot of these immature cervices have atypical cells early on that just go back to normal all by themselves when left alone. Now, if you're doing an exam on somebody and you see a very funny, abnormal-looking cervix, by all means, do a Pap test. And I try not to test my patients when they have acute infection either. If someone comes into me with chlamydia or GC, I'd rather not do their Pap test then. It's going to be abnormal. They're going to have atypical cells. So I try to get them back and then do their Pap test when they're healthy. Or by age 21. It used to be by age 18. Now it's by age 21, if not sexually active. So those are the new guidelines. And keep your eye on the recommendations for what to do with teenagers who have atypical squamous cells, because that's changing too. I think there was just a big OBGYN meeting, and they determined that those patients should just be followed. And so that's something that probably will come out soon. Yes?
Any comments or thoughts about kind of the reported increase in oral sex in teenagers these days? Anything specific that you discussed with them about that, or are you finding
about oral, about
teenagers having more oral sex now, kind of treating it as more casual?
You know, it's something that a lot of teenagers don't consider sex. So when I ask my teenagers if they've been sexually active, I'm very upfront about it. I say, so you haven't had sex. If I'm talking to a girl, I say, so a boy has never put his penis in your vagina, your rectum where the poop comes out, or your mouth. And I'm just very blatant, and I do the same thing with boys. So you've never put your penis in a girl's mouth, rectum, or vagina. And so they know I'm talking about all of those things. And we talk about it because I tell them you can get infections from doing any of those things. But yeah, a lot of kids don't think that makes it into the having sex category, and I think it's important to talk about all of the having sex categories. I will say, I think that teenagers should be screened for substance use. The CAGE questions are the adult questions. The CRAFT questions are studied and are better in adolescents, so I'd encourage you to find out a little bit about the CRAFT questions. Do you use while you're in the car to relax while you're alone? Do family and friends think you have a problem? Have you used and forgotten what happened when you were using, or has using ever gotten you into trouble? Those are really good questions to ask adolescents to tell whether they're having a problem with substance abuse. Obviously, a lot of adolescents are going to try things. That's what adolescence is all about. Testing limits, trying new things. We want them to try new things. We want them to test their limits. It's how you become an adult, but we hope that they do it in a very safe way. And we hope that they don't do it with certain things that are incredibly addictive, like meth, which is a big problem in the Omaha area and in Nebraska, I think, as a state. Urine drug screens, in parting, I think I have to say something about them. They can be very useful if you have a patient who's obtunded and you don't know why, or if you have a patient who has a problem and you're monitoring their problem. Keep in mind that a urine drug screen only covers 24 to 48 hours. So if they haven't used in the past day, you're not going to catch it. And I counsel all my patients and their parents, if they think that if a parent thinks their child needs a urine drug screen, they need counseling. Whether the screen is positive or negative, they need help. That's the sign that they need help, that the parent thinks they need the screen, not whether the screen is positive or negative. I try to get my kids to get screened if parents want them to get screened, because I tell them, if you refuse, I can't do the screen, but you're guilty. Your parent will see that as you being guilty. So take the screen. If you're positive, then we have some serious things to talk about. If you're negative, you can say to your parents, see, I told you I didn't use anything. Seriously, and so it's a good idea. Just do the screen. I'm going to tell your parent, I think you need to go to counseling, because obviously you don't trust each other. And if you don't trust each other, there's a huge problem, whether you're positive or not. So that's my stance on urine drug screening. I never do a urine drug screen on a teenager without them knowing about it, because that's lying to them, and that's not what I'm about.
How do you frame your questions about homosexual activity to teenagers?
How do I frame my questions about homosexual activity? Are you having sex with anyone of the same sex or opposite sex? Do you have a boyfriend, girlfriend, both? Those sorts of questions, and if so, what sorts of activities have you participated in, and how do you feel about that, and how do your parents feel about it? Do they know about it? Have you talked to people about it? Is it something that that there are other people who know about, or is this something that you don't tell anybody about? Has it caused you a lot of stress? Have you talked with counselors at school, your minister, those sorts of things? I think that it's an important area to talk about. I try not to box adolescents in by asking girls, do you have a boyfriend? And by asking boys, do you have a girlfriend? I try to ask them about special people in their lives. Who's the most important person besides your family in your life right now? And how close are you to them? Have you become sexually active? Have you ever had sex with someone of the opposite sex, someone of the same sex, those sorts of things. I do think that's important, that if you box people into heterosexual activity, they're never going to talk about anything else, that's for sure. So if I ask all my girls, do you have a boyfriend, they're not going to talk about weird feelings that they have about the girl that sits next to them in math class.
When do you go to the bleeding times and the dysfunctional uterine bleeding? You don't get that in every patient, do you?
No, absolutely not. I had a patient who came in recently who I did it on, who had her first period, and it lasted for 6 weeks and it wouldn't stop. That's the typical patient from early on. They have lots of serious prolonged bleeding. Those are the patients that I run that stuff on.
Okay.
And to be honest, it's very rarely positive. Right. Very rarely. So if someone just comes in, they've had normal periods but a little prolonged and a little, I don't always do them in those patients.
Yeah, we just had a talk, and he said it was like 1 in 1,000, and he recommended doing it on everybody, and I was thinking, geez.
Oh, heavens.
That would be a different.
I've probably done bleeding studies on 5 patients in the past 10 years for that reason.
Have you got positive ones in those ones? Or?
I have not.
Okay.
I've never had a positive.
Okay.
So, and they usually present with bleeding from other things. It seems like not, but I'm still looking for one. I'll find one eventually.
One other question. I work in the emergency room, and you mentioned not doing urine drug screens, without consent. Well, I mean, I typically do those without consent.
It depends
I mean,
too on whether
yeah, I don't really have that kind of relationship that
Yeah.
you have, and I was just wondering if you thought there was a problem with that.
I think that if your patient is altered mentally, that it is appropriate care. I mean, you have if your patient is altered, you may not be able to get their consent appropriately, and if you're trying to figure out what's wrong with them, then that's very appropriate. I think if your patient's not altered and you're doing one, I think I would tell them, we need your urine. We're going to check it for infection, and because you were involved in a car accident, we have to check and make sure that you weren't, to do a drug screen on you. I think that's a reasonable thing to tell them. I think that if you're worried they won't give you the urine, then you get the urine first and then you tell them. But you got to tell them, and they can say, I don't want you to do that test. But I think you have to have a decent reason for it. I mean, if somebody comes into the emergency room and they've got a horrible sore throat and they can't swallow, you're not going to do a urine drug screen on them. You've got a reason for doing them on the patients you do them on.
Sure.